Hello and welcome to Access Chat. Glad to welcome Kate Nicholson back to Access Chat. Kate is a returning guest. We were delighted to have Kate back because Kate has now founded something called the National Pain Advocacy Centre. So we featured you before, Kate, and you've been in the field of ADA law and expertise for a long time, but your particular field of knowledge and passion has been around pain, and it's great to see that you're bringing this topic to a higher level and bringing some organization around this. So yeah, welcome back, great to have you here again, and also please tell us about NPAC.
Sure, thank you. Well, as you explained, my whole career has been in disability rights. Traditionally, I was a civil rights attorney for the U.S. Department of Justice. But during, I would say in the last 3 or 4 years, I have focused much more specifically on the issue of pain and pain treatment and access to appropriate medication. So NPAC, National Pain Advocacy Center, is really an alliance of scientists and clinicians, people with human and civil rights and disability rights backgrounds, as well as health policy and drug policy backgrounds, and then a rich group of people with lived experience of pain, but also some people in recovery from addiction, because these issues have sort of intersected in, particularly in the US and Canada, but also in the UK and other countries with what's been called an opioid crisis. So we came together because we were concerned about people losing access to necessary medication. There have been a lot of sort of corrections in liberal prescribing that are ending up affecting, overreaching, and affecting people who rely on pain medication for serious conditions, cancer, sickle cell, MS, who are no longer able to fill their prescriptions at the pharmacy, who are often now, we see, not even able to find doctors willing to treat them at all, and who are being subjected to a dangerous practice of forced or involuntary opioid cessation or tapering. And so we came together to work on addressing those ills, but our focus is actually much broader. We really believe that pain is misunderstood by the larger culture, that people need to have a deeper understanding of its consequences, that there are important health equity considerations when it comes to pain, where people of color often have their pain rated lower by clinicians, rated as less severe because of implicit and explicit bias. And there are lots of studies that show that. And also because of the way that we've sort of waged the drug war disproportionately against communities of color, they're more likely to be perceived as drug seeking and not get adequate pain medication, even after surgery or in the emergency room for acute pain. Women disproportionately are affected by pain. Some studies show that up to 70% of people with chronic pain are women. Women's pain is commonly dismissed or disbelieved. And there's sort of interesting new research. You know, it was only in 2016 that NIH in this country started requiring that some testing be done, not just in male lab rats and animals, but also in female. And what we've learned is that, at least in animals, entirely different cells are involved in pain processing, or what makes pain become chronic in males and females. So there's some interesting issues related even to, believe it or not, discrimination and sort of how we conduct our research on a gendered basis. Pain is the chief cause of disability globally and in the US. Poorly managed pain is. People with disabilities, Deborah and I were just talking about this, people with intellectual disabilities, other disabilities often have their pain dismissed or disbelieved, their communication barriers. People who are trans may experience more severe pain and greater barriers to care. Oh, I'm so sorry. Apologies, I can't believe I didn't turn that off. Anyway, so our focus is broader. A lot of, there's a big misunderstanding about pain and we want to sort of shift the conversation, but I'm sort of rambling on. So
No, that's fine.
not
And
me.
that's a whole lot of issues to
It
unpack
is.
in that intro, so obviously much needed to have an organization that's sort of advocating on these issues. And we've covered these before, and you're not the only person that's come on amongst our guests that have expressed their concerns about the way that and the prejudices people have towards pain and medication,
Right.
from and all of the stuff about the sort of the innate biases is rings really true, and it also rings true to other forms of medication too, as well. So but I've watched the culture of fear, particularly in the States, that's happened where now doctors are really afraid to prescribe pain medication, which seems to me really, really unhelpful. And the I'm going to say optics around pain and opiates have really had an adverse effect, disproportionately adverse effect on people's lives and people's abilities to live a good life. And so, fully, behind what you're doing. So just one question, why just national?
Um,
Got to start somewhere, right?
Actually, our focus isn't just national. That's just sort of the name we came up with. We actually have several people, both in our community council and our science and policy council, who are Canadian and people from other countries. That's it's
No. So I'm fine. I'm just teasing a little, but actually, it's an issue that crosses borders, though. So
it absolutely is.
We need you, outside of the US as well. So
and we will work outside the US as well.
Yeah.
Yes. But I think the focus originally was nationalist because there were a lot of different things happening in different states, and our policy focus is really more federal, broader, but it's certainly not just limited to the United States.
Kate, I know we were talking off air, about my daughter, Sarah, who will be 34 years old in a couple of days. She continues to remind me like I'm going to forget. But I didn't realize that, she was living with chronic pain. I mean, when we had you on the first time, and it's now that we understand what she's dealing with and dealing with the pain medication and the management, it is very interesting and complicated. And I know that she just had a toenail removed, and that didn't sound like a big deal, but it actually wound up being a big deal just because the chronicness of it and blah, blah, blah. And they didn't give her any pain meds. And she got home later and she was in extreme pain. And somebody, a staff member had taken her with her supported living. But I think, like you said, and like Neil commented on, there's so many really, really complex issues here. And my question is, did you see any of the complexity shift and change during COVID? For example, I know that there were certainly a lot of health concerns during COVID with people with disabilities, including intellectual disabilities, whether or not, for example, Sarah would be eligible to get an incubator if she got in trouble, during this crisis. So I was just wondering if, how, because things must have shifted, but how have they shifted during this COVID experience?
Yeah, well, I think, that's a big topic as well. I mean, certainly a lot of people with chronic pain or pain generating conditions were more vulnerable to getting COVID-19, were at higher risk, either because of their underlying conditions, whether they be intellectual disabilities, actually, and one underlying condition that put people at greater risk, but with chronic pain, people with autoimmune disorders, people with cancer, or people taking steroids or chemotherapy for certain chronic conditions also put people at higher risk. So there was that layer. I know early on, there were a lot of problems with essential services being shut down, what was considered essential. And there are a lot of services that people with chronic pains use to keep their pain at an equilibrium, and those were unavailable for a period of time for people. On the prescribing issue, there were some positive developments. The Drug Enforcement Agency in the United States actually allowed expansion, temporary expansion of telemedicine prescribing, which generally is not done. And so there were some attempts to accommodate, I think, the needs of people with pain in the context of COVID-19. I would say that also in long COVID support groups, pain is a chief complaint of people who have long COVID. So there are lots and lots of layers to the COVID aspects. And of course, when you're talking about people who need sort of home and community-based services, or that was a big issue. People didn't have sufficient PPEs, and so they weren't showing up, putting people at greater risk of being put into institutions. And of course, anyone in an institution we've seen, was at substantially higher risk and more isolated. And there are psychological factors from isolation. A lot of people with chronic pain also have anxiety, depression, and I think the further existential state of being in pain is one of isolation. So being more isolated, I think, has been challenging and problematic for many people. This is what happens with these, other health crises, is that those who are already underserved and more vulnerable end up suffering disproportionately.
Well said. Antonio, you have a question, right?
Yes, I do. There was recently a study that was looking at the side effects of COVID after 6 months, and according to it, independently of the situation, could be just someone with no symptoms but who has been infected, or someone who had serious symptoms. They were both affected in the same way, and those symptoms are still they are started to be investigated and researched, but they are not yet clear. In relation to the topic of the conversation today, do you know if anyone is doing any type of research in terms of COVID and pain and long-term effects? Because I feel that is sometimes people feel, oh, I didn't have any symptoms, everything is fine with me, but there are long-term consequences that can have a huge social impact in society.
Yeah, that's a good question. I think there are a number of researchers looking into long COVID or post-acute sequelae syndrome. They have different names for it. And I know that some of the big associations, like the U.S. Association for the Study of Pain, has also raised this issue, the pain connection. I interestingly myself developed long COVID. I'm fine now, but I got COVID over a year ago in April last year, very early when it first came to Colorado, where I live. And developed long-term encephalitis and meningitis. I had to be on steroids for a very long time just because my brain was very swollen. And whether that was connected to other pre-existing conditions or just nobody really knows, right? As you say, and it is true that some people have long COVID symptoms without having been asymptomatically infected to begin with. There's a lot we're still, in some ways, it's been remarkable to see how much we've learned about this virus that's really not been around for very long. In some ways, the scientific uptick on it has been astonishingly fast compared to other viruses. If you think about HIV or other viruses and how long it took us to really understand them. But in other ways, because it's such affects so many different body systems and affects people so differently, it remains, a mystery.
There's a new administration in the United States. Have you observed any shifts in healthcare that can somehow be more friendly in terms of the approach to patients and to the engagements with doctors?
I haven't really, I think there's a more compassionate administration for sure. I think there's been a real focus rightly on getting people vaccinated and, the immediate emergencies more than I've seen a real shift in, I haven't seen a real shift in concerns about access to medication or any of those kinds of issues. But I do think that there has been a focus on healthcare and access, and at least, it's really been an emergency focus, though, mostly on stemming the crisis and the pandemic. Although there has been some good expansions for people with opioid use disorder and addiction, where there are steps to address the continued drug overdoses in the US. I mean, they recently just shifted a policy in which federal money could be paid for testing the street supply, for example, which didn't used to happen. And that's really what's killing so many people today, is there's an increasingly potent street supply that's tainted with carfentanil and fentanyl and these very, very potent, we use carfentanil to tranquilize elephants. I mean, very potent substances. So there have been some shifts, not necessarily in the area in which I am advocating in terms of the administration. But we recently had a good policy victory in the Congress. There was an attempt to impose a strict federal limit for all initial opioid prescriptions of 2 days, regardless of someone's health condition. And that was going to be introduced, that was introduced in a bill that was introduced in the last Congress. And we were able to get that removed from its reintroduction in this Congress. And that was really important because there's a very, there's of course a big range of conditions. If someone's had a major surgery or a double hip replacement, then probably they will need more than a 3-day supply. Having to return to the doctor every 3 days if you're in a rural area and have to travel to an urban area, if you don't have good transportation access, if you are burdened by additional copays, all of those problems exist. But what we've also seen is that in the states, some of these kinds of laws have been enacted. And what's happened is that even though chronic pain is supposed to be exempted, it in fact is not. People with chronic pain, people with cancer, people with sickle cell who may have episodes or episodic pain, end up falling through the cracks. And so that was a good recent victory.
Yeah, it astounds me that they could put such a short limit, upper limit on prescription length, because for all of the reasons that you just stated, even in the UK, where I'm in a privileged position where we have a national health service and you pay very little for prescriptions, the time lag to get a repeat prescription, to get to see a doctor, to then get to the pharmacy and get that prescription, I would say that 5 times out of 10 it would be impossible to get that done in time to have continuity of medication. So you're pretty much saying you've got a 1 in 2 chance of putting someone back into unnecessary pain,
right,
through that legislation, maybe higher. Even in a country where it's really well organized and publicly funded.
Yeah, no, it's problematic. And again, there are people face, barriers at the pharmacy anyway. So having to go every 3 days would have been, challenging. And it's important for people to heal, for example, post-surgically. We all know that pain is a normal body function when it's adaptive. It teaches us that we need to go rest or seek care, but that when it's very severe, even when it's acute, we don't heal well unless it's treated, and that's why we treat pain after surgery. But the other side of the coin is that what a lot of people don't understand is that when pain becomes chronic, it doesn't serve that adaptive function anymore. It actually behaves more like a disease because it damages every body system. And so it becomes especially important to treat in a chronic pain situation. So when you have people sort of across the spectrum of serious acute pain into chronic pain, palliative care, cancer pain, potentially being denied access to medication, that has some very serious consequences.
Yeah. And all of these bits of legislation, I mean, they weren't, I understand they weren't started out with the intent of harming people, but the consequences of these policies is clearly, to my mind, harmful. And I think it's great that the work that you're doing at the center is bringing science into that and bringing these different groups together, because often the voices of the patients aren't listened to.
Right.
So hence why you need the scientists as well. I am, really curious about attitudes to drugs, right? Because we have a really weird relationship as humanity with medicines and intoxicants. And some of this is cultural.
Yes.
And so, we know that, like you said before, that different ethnic groups get treated differently, and different ethnic groups have had traditions of using different substances to treat pain and also for pleasure and recreation and religious observance and all sorts of things. Do you think that we need to change our entire attitude to how we view and sort of evaluate these substances as a whole, not just opiates, but our attitude to what we put in our bodies and how we regulate some of this stuff, because it seems tremendously disjointed.
I think it is disjointed. I think, there's pretty good research that the history, at least in the United States, of drug policy really has a lot to do with xenophobia and racism in terms of which substances are banned and which substances are permitted. I do think that, prohibitionist drug policies can be very destructive. Certainly what seems to have happened in terms of the escalating overdose deaths, where you've got an increasingly potent and dangerous supply when the legal or prescribed opioids were limited. So, I mean, I do think, there is a broader question about drug policy, and I think that almost invariably supply side efforts to have failed, and have failed people of color in particular, or certain communities more than others.
Yeah, no, I think it's a problem that I don't have the answer to, but I'm conscious of, because I actually am prescribed a controlled substance. So for my condition, and it helps me. But if I didn't have a prescription, it would be illegal, and so. But it has positive effects on me. So I think that that there is a false dichotomy that we see with these things, where we go, oh well, that's a stimulant, it must be bad. Well, coffee's a stimulant.
Right.
Guarana is a stimulant.
Right.
We have these nostrums as these ideas as a society that are based upon our prejudices and our innate biases. So I think that's really, we need to look at this from a multicultural point of view, bringing in these people. So I mean, I look at your extended board, and you've got a wide plethora within NPAC.
Yeah.
So, I mean, tell us a little bit more about the people within NPAC that you've brought together, because I think that it looks like a really amazing community of people and contributors.
Yeah. So the people on our board is a fairly small board. It's myself, Laura Mills, who works for Human Rights Watch and wrote a really important report in December of 2018 about what was happening to people with pain, being denied medication or health care, is on our board. Julie Reskin, who runs the Colorado Cross Disability Coalition. She's their executive director, is really a rock star disability rights advocate, lives with MS, and requires some prescribed medication to manage that. Dawn Gibson, who has established many years ago a Twitter chat called Spoonie Chat, which is a chronic pain Twitter chat, is on our board. And also Jonathan Mayer, who's a recently emeritus professor of epidemiology at the University of Washington, who has written about his own experience with undertreated pain, and the drive that propels him to work on pain research and also to teach about pain. He teaches one of the few undergraduate courses about pain in the country. We have a Science and Policy Council with experts in a variety of different areas related to pain. Dr. Samin Ali, who is Canadian, we're not just based in the US, despite our name, is an expert in children's pain and how we treat children in pain affects their development and their lifelong relationship with healthcare. So that's a really important issue. We have Dr. Tamara Baker, who's an expert not only in sort of gerontology and how we treat older people in pain, where pain is a chief complaint of older Americans and older persons, but also an expert in racial disparities in pain care. And just a number of Dr. Sean Mackey, who's the head of pain management at Stanford and has been very involved in pain policy, quite a number of pain folks, then quite a number of disability rights and human rights folks in our, Lindsay Barron runs policy for NICL, the National Centers on Independent Living. She and I together for many years have co-chaired a task force, a chronic pain and opioids task force there. And we have a number of people with other people with expertise in pain policy. We also have a number of doctors with expertise and scientists in addiction and drug policy experts, professors who have looked at these things that we're talking about, like sort of prohibition and drug policy and how they affect people and how they can generate stigma and lead to barriers to care. And then we also have an extensive community council of people with lived experience. A lot of people. We talked about Tinu Abayan Paul, who's a sort of rock star chronic illness and disability rights advocate. Cherise Hill, Ola Ojibumi, Sarah Blahovic, lots of folks who many people in the disability rights community will recognize and know. And we also have people in our group, in our community council with lived experience of addiction and who are in recovery as well. Because of the way these issues have intersected in our culture, we feel like it's very important to bring everyone to the table in this conversation. We don't think we're, going to solve this problem by just looking at it from a single angle.
Yeah, no, I was impressed by the breadth of the group, and I think it's really really useful to have that breadth, and you've obviously put a lot of thought into bringing this collection of people together. So I think it's really exciting to see you bring this together to start hopefully moving the needle on this, because if anything, since we first started having conversations, things have got worse, not better, despite our community's understanding of this increasing, because I mean, even amongst the disability community, quite often pain has been dismissed because it's hidden and everything else. So thank you very much for the work that you're doing. Thank you again for joining us, telling us about it. Hope that you come back, in a short while and tell us about NPAC now being INPAC or something, and being a global movement on this stuff because it's super needed. Yeah, if you've got research to share and stuff like that, I'm really very interested and will of course share. And of course I also need to thank Barclays Access, MyClearText and MicroLink for keeping us on air, keeping us captioned, keeping us here and helping us serve the community. So thank you very much.